Welcome to the deep dive. Today we're getting into something really critical in pediatric nursing. How we care for kids with infections.
Yeah, absolutely essential.
We've pulled together the core ideas from Chapter 15 of Essentials of Pediatric Nursing. Our mission, to quickly get you up to speed on the key physiological differences in kids, the nursing process, and how to spot common childhood infectious diseases.
And it's so important because, well, infections are a huge deal globally, and kids are just uniquely vulnerable. Their immune systems are still figuring things out.
Right.
Plus, think about toddlers, everything goes in the mouth, right? Hand hygiene isn't exactly their strong suit yet. So understanding all this is key for, stepping in early.
Definitely. So we want to go beyond just textbook definitions today. We'll look at what that immature immune system means clinically, walk through assessment, and really focus on some high-stakes infections and telling them apart. Okay, let's kick off with part one. Why are children's bodies sort of uniquely challenged by pathogens? What makes them physiologically more vulnerable?
Well, the big one is that developing immune system. You've got cellular immunity, that's kind of the fast general defense, which is mostly working at birth.
Okay.
But then there's humoral immunity, that's the memory bank, the antibodies. And that part needs time and exposure, either getting sick or getting vaccinated to really build up.
So it's like learning on the job, immunologically speaking.
Exactly. And there's this window, that they lose the passive immunity they got from mom through the placenta and breast milk, but they haven't finished their own vaccinations yet. That leaves them pretty exposed for a while.
That cellular versus humoral distinction is really helpful. And when we talk fighting infection, white blood cells are the stars, right? Could you break down who does what?
Sure. Think of it like a defense team. Neutrophils are your first responders. They rush in, they're phagocytic, meaning they eat up bacteria. Really crucial frontline guys.
Got it.
If things get heavier, monocytes show up. They're like the second wave, tackling more severe or larger infections. And then lymphocytes, they're the specialists, core to that specific adaptive immune response. Super important for viruses like measles or chickenpox.
All right, let's switch gears to something parents always worry about. Fever. It feels like the enemy, but the book points out it's actually a deliberate defense. How does the body even do that, turn up the heat?
Yeah, it's fascinating. It's all orchestrated by the brain. Pathogens make the body release these chemical messengers, endogenous pyrogens.
Okay.
These travel to the hypothalamus, that's the body's thermostat, and basically tell it to produce prostaglandins. This action cranks up the body's temperature set point.
So the body wants to be hotter.
Exactly. And to get there, you see the child start shivering, their blood vessels constrict in their skin. That's the cold response. It traps heat and pushes the core temperature up to that new, higher setting.
And we need to be clear. This is different from hyperthermia.
Oh, absolutely. Critical difference. Fever is regulated, controlled. Hyperthermia, like heat stroke, is when the body's temperature control system fails completely. And the book makes a really important point. In a neurologically healthy child, the body actually has its own brakes. It produces something called cryogen that stops the fever from just skyrocketing indefinitely.
That's reassuring. It puts fever management in perspective then. When do we step in with meds like Tylenol or Motrin? It's not always about hitting that perfect 98.6, is it?
Not at all. The main reason to treat is for the child's comfort. Fever makes you feel lousy, and it also increases metabolic rate, which means the body needs more fluids. So it helps prevent dehydration, too.
Makes sense.
The two go-tos are acetaminophen, or APAP, and ibuprofen, IBU. There's some evidence, like in EBP 15.1, suggesting ibuprofen might work a bit faster, bring the fever down more, and last longer.
So maybe better for bedtime relief.
Potentially, yeah. Longer relief could mean better sleep for everyone.
Okay, but safety first, always. Big red flag. Never give aspirin to kids with fever.
Absolutely non-negotiable. The risk of Reye syndrome is just too high. It's a devastating illness affecting the brain and liver.
And another practice the book cautions against: alternating acetaminophen and ibuprofen. Why is that risky?
It really boils down to the risk of errors. Parents are stressed, tired, trying to juggle two different dosing schedules, one every 4 hours, one every 6. It's just too easy to get confused, maybe give a double dose by accident, or give doses too close together.
Yeah, I can see that.
Sticking with one medication and following its specific instructions carefully is just much safer.
Okay, let's move into part two. Infection control and assessment. The chain of infection is fundamental agent, reservoir, portal of exit, Transmission, portal of entry, susceptible host. Where's our biggest leverage as nurses to break that chain?
Hands down, frequent hand washing. The book hammers this home. It's the single most important thing.
Simple but powerful.
But, for this audience, let's add a layer. If you're dealing with something like norovirus or C. diff, alcohol-based hand sanitizers don't cut it. You have to use soap and water. So effective hand hygiene isn't always the same thing. It depends on the bug.
Good point. That leads right into isolation precautions. We have Tier 1, standard precautions used for everyone, right? Bodily fluids, except sweat, broken skin, mucous membrane.
Correct. Baseline for all care.
Then Tier 2 is transmission-based, airborne, droplet, contact. Why aren't standard precautions usually enough on a pediatric unit?
Well, think about it. Kids, especially little ones, can't always control their secretions or bodily fluids. They put shared toys in their mouths. They might be incontinent.
Right.
Standard precautions kind of assume a level of control and hygiene that a toddler just doesn't have. So very often in PEDS, we need those extra layers of protection found in transmission-based precautions, especially for kids who can't contain their germs easily.
Makes sense. Okay, shifting to the actual nursing assessment. When you're taking a history, what are the absolute must-ask questions or key pieces of information?
Obviously, you need to know about any known exposures to illness and definitely their immunization status. But beyond that, pay huge attention to those vague, non-specific symptoms. Like the parent saying, he's just so tired, or she's not acting like herself. Those comments can be incredibly important early clues, especially for something serious like sepsis starting.
Okay. And during the physical exam, obviously we look at rashes. But what else signals dehydration or a worsening infection?
Yeah, rashes need a detailed color, shape, where it is on the body. But you have to look closely at hydration status. Are their eyes sunken? Mucous membranes dry? Check skin turgor. How's their capillary refill?
Vital signs too, I assume?
Crucial. Tachycardia, fast heart rate, and tachypnea, fast breathing often go along with fever. But the really scary one is hypotension, low blood pressure. That's a late sign. It means things are progressing towards septic shock.
And there's that tricky thing with newborns.
Right. The neonate paradox. Infants under a month old might actually have a low temperature or just normal, even with a really serious infection. So you can't rely on fever alone in that age group.
Good reminder. What about diagnostic tests? The chapter mentions CBC, ESR, CRP, cultures. Can you quickly recap what these tell us?
Sure. The CBC, complete blood count, gives us the white blood cell differential we talked about earlier. High neutrophils might point to bacteria. High lymphocytes often suggest a virus.
Okay.
ESR and CRP SED rate and C-reactive protein are general inflammation markers. They tell you something is going on, but not specifically what.
And cultures.
Cultures are key for identifying the specific bug. Blood, urine, spinal fluid, wound swabs, throat swabs. But the golden rule, absolutely critical, get your cultures before you give the first dose of antibiotics.
Why is that so important?
Because if you give antibiotics first, they can start killing the bacteria, and your culture might come back negative or inconclusive, even if there was an infection. You lose your chance to know exactly what you're fighting.
Got it. Makes perfect sense.
Yeah.
Now let's talk atraumatic care. Getting blood drawn is scary for kids. What works best to make it less traumatic?
First off, try to protect their bed as a safe zone. Do procedures in a treatment room if possible.
Good idea.
Use topical anesthetics like EMLA cream, that numbing cream, whenever you have time for it to work. And for infants getting heel sticks, things like non-nutritive sucking, a pacifier, and giving oral sucrose solution can really help manage pain. These aren't just nice extras, they're evidence-based ways to reduce distress.
Building trust, too. Right.
Absolutely.
Okay, Part 3. Nursing interventions. Let's hit the big 3 diagnoses. Impaired comfort, risk for deficient fluid volume, and social isolation. For comfort, besides meds, what's a key non-pharmacological tip or warning?
Okay, so things like light clothing, cool compresses are good, but if you're trying tepid, sponging, lukewarm water, you have to stop if the child starts shivering.
Yeah.
Because shivering is muscle work.
Yeah.
It actually generates heat and increases their metabolic rate, completely counteracting what you're trying to do. It makes things worse.
Ah, okay, good point. And for fluid volume risk, how do we get fluids into reluctant kids?
Get creative. Encourage whatever fluids they like within reason. Popsicles are often a winner. Make games out of drinking small sips. Pedialyte makes freezer pops too.
Nice.
And then monitor really closely. Track intake and output. We're looking for urine output of about 1 to 2 milliliters per kilogram per hour. Check for moist mucous membranes, good skin turgor, signs they're staying hydrated.
And finally, social isolation. Being stuck in a room is tough for kids. How do we lessen that psychological burden?
Number one is explaining why they're in isolation in age-appropriate terms, making it clear it's not a punishment.
Yeah,
Visit frequently and make those visits count. Try not to be interrupted. And if you have to wear a mask, let the child see your face first, talk to them, then put the mask on. It helps reduce that scary barrier effect.
great tips. All right, part 4, quick clinical snapshots. Let's start with the big one, sepsis. We need to really define this and stress the warning signs.
Okay, sepsis. This is critical. It's the body's overwhelming systemic overreaction to an infection. It can quickly progress to septic shock, which is life-threatening.
Who's most at risk?
Infants under 1 month, definitely, and any child who is immunocompromised.
And the signs aren't always obvious, right? What are the red flags?
Right. Often it's not high fever. It might be lethargy, just really floppy and unresponsive, extreme irritability, poor feeding, signs of poor perfusion, like cool, mottled skin. And again, in newborns, hypothermia, a low temperature, is a huge warning sign. That just not acting right feeling parents describe is vital information here.
And management. What's the priority?
Speed. Get cultures immediately, blood, urine, CSF if indicated. Then start broad-spectrum IV antibiotics right away. Do not wait for culture results to start treatment. Time is absolutely critical.
Got it. Okay, moving to some common bacterial infections. Community-acquired MRSA, what does that typically look like?
Usually it's a skin infection. Starts as a red, swollen, painful bump. Often gets mistaken for an insect bite or a spider bite initially.
And prevention.
Good hand hygiene, keeping skin intact. Basic stuff, but really effective.
What about scarlet fever? That's linked to strep throat, right?
Yes, caused by group A strep. The key things to look for are the rash, it feels rough, like sandpaper, and the tongue, which can look bright red with prominent bumps. They call it a strawberry tongue. Usually penicillin or amoxicillin. And importantly for schools and parents, the child isn't contagious anymore after 24 hours on antibiotics.
Good to know. And diphtheria, less common now thanks to vaccines, but still important.
Absolutely. The big danger with diphtheria is the thick grayish membrane, a pseudomembrane that forms over the throat and tonsils. It can actually block the airway. It's a stark reminder of why routine vaccinations are so vital.
Definitely. Let's talk vector-borne ticks. Big difference between Lyme disease and Rocky Mountain spotted fever.
Right. Lyme disease from the deer tick. The classic early sign is often that erythema migrans rash the bullseye. Looks like a ring.
Treatment depends on age.
Generally, yes. Because of potential teeth staining with tetracyclines, doxycycline is usually for kids over 8 and amoxicillin for younger kids.
Okay, but Rocky Mountain spotted fever, RMSF, that's a different story, isn't it?
Totally different and much more severe, potentially fatal. It's a rickettsial illness. The rash often starts differently, too, on the wrists, ankles, forearms, then spreads fast, including to palms and soles, and it can become petechial little pinpoint bruises.
And the treatment rule changes here.
It does. This is a critical point from the chapter. Because RMSF can kill quickly, doxycycline is the treatment of choice for all ages, even young children. The risk from the disease outweighs the potential risk of teeth staining in this case. It's a crucial exception.
Wow, okay. That's vital to remember. Quick hits on viral exanthems, those childhood rashes.
Yeah.
How do you tell measles, rubiola from chickenpox, varicella? Any key clues?
For measles, look for the prodrome first, the cough, runny nose, conjunctivitis, pink eye. Then the really specific sign comes before the main rash. Koplik spots, little white or bluish spots on the inside of the cheek, the buccal mucosa, pathognomonic, meaning if you see them, it's measles.
Okay, and chickenpox.
The hallmark of chickenpox is seeing lesions in all different stages at the same time. So you'll see some flat spots, macules, some raised bumps, papules, some fluid-filled blisters, vesicles, and some crusted-over scabs, all coexisting on the child's body.
Got it. Finally, let's touch on parasites, lice, and scabies. Common and often cause a lot of anxiety.
Yeah, head lice, pediculosis capitis, and scabies. Scabies is known for intense itching, especially at night. The key nursing message here is immediate reassurance.
How so?
Tell the family straight up, this is not about being dirty or poor hygiene. These things happen in all communities, all socioeconomic levels. Then you provide clear, detailed instructions for treatment, the topical meds, washing bedding and clothes in hot water, treating close contacts. But you have to do it while managing that potential embarrassment or stigma.
That balance sounds tricky.
It is. It's about being clinically thorough, but also psychosocially supportive, so they actually follow through with the whole plan.
And briefly, STIs in adolescence. A sensitive but important area?
Yeah, Adolescents are biologically more susceptible to some STIs, plus they often face barriers like confidentiality concerns or just lack of access to care. Our role as nurses is huge here. Provide confidential, non-judgmental assessment and counseling. Educate thoroughly out prevention abstinence, yes, but also correct and consistent use of barrier methods like condoms.
Ah,
So, wrapping it all up, the pediatric nurse's role in infections is really multifaceted. It's about sharp assessment skills, picking up on the subtle, vague signs, especially for sepsis in young kids.
mhm.
It's about rigorously following infection control hand hygiene, isolation to stop the spread, and it's about clear, compassionate communication and education with the family for both treatment and prevention.
Absolutely. Building on that idea of balancing clinical needs with psychosocial support, especially with things like scabies, here's a final thought for you to consider. Imagine you have a 10-year-old diagnosed with scabies. How would you, as the nurse, deliver all those necessary, very detailed instructions about cleaning and treatment, which can feel invasive or even blaming, while also actively reducing the child's and family's feelings of embarrassment or fear of being judged? How do you ensure they fully adhere to treatment by addressing both the clinical and the emotional side? It really highlights that art of nursing, doesn't it? Thank you for joining us for this deep dive into pediatric infectious disease care. Keep learning, stay curious, and keep providing that excellent care.